Hi, this is Sonya Hawkins, and this is my case study on herpes zoster. This is George. George is a 56-year-old male. He came to the clinic today to discuss his diagnosis of herpes zoster and medication options. He came in complaining of pain over the right side. In his words, "I started having itching, pain, and tingling sensations on the right side of my chest and back. The Tylenol I took wouldn't make the pain and itching go away. I also had headaches and felt uncomfortable in general. I was feeling sluggish and run down for the last couple of days before this rash showed up." Herpes zoster, or shingles, is caused from a herpes virus, and this is the same virus that causes the primary infection, chickenpox. When the chickenpox resolve, the viral particles actually stay and lay dormant within sensory nerve roots, and they could stay and lay dormant for years to decades. And shingles is from the reactivation of this virus, varicella zoster. Shingles has three clinical phases: the pre-eruptive phase, the acute eruptive phase, and the chronic phase. The pre-eruptive phase is otherwise known as the prodromal phase, and this is where the patient will experience unusual skin sensations or pain within the affected dermatome. And this can be tingling, numbness, and they will also sometimes experience flu-like symptoms, headache, stomach ache, nausea, and just a general malaise. This phase can last anywhere from 1 to 10 days. The second phase is the acute eruptive phase, and it's during this phase that the rash appears. The lesions begin as erythematous macules and papules that quickly develop into vesicles. The lesions tend to form over a period of 3 to 5 days. And once they form, they go through the stages of rupture, releasing their contents, ulcerate, and finally crust over and become dry. And it's at this point that the patient is no longer infectious. The last phase is the chronic phase, and this is characterized by a persistent or recurring pain lasting 30 or more days after the acute infection and the lesions have all crusted over. This is the most frequent complication observed, and this is the post-herpetic neuralgia. The pain can be very severe and incapacitating and may take a long time to resolve, especially in older adults. It can last longer than 12 months. The reactivation of the varicella zoster virus is not really understood, but some suggested causes include external re-exposure to the virus, acute or chronic disease, medications of various types, and emotional stress. Known risk factors all relate to the status of cell-mediated immunity to varicella zoster virus, and this generally declines with age. The complications of shingles also increase with age, and as I mentioned, the most common is the post-herpetic neuralgia. Others can include ocular complications, motor neuropathy, meningitis, and herpes zoster oticus. George reports numbness, tingling on right side. He reports a body malaise, localized pain rated a 7 out of 10, slight loss of appetite because of the pain, and is temporarily relieved by Tylenol, 500 milligrams. He noticed a slight red rash when looking in the mirror 2 days ago. George denies prior hospitalizations, surgeries, accidents, and does not remember immunizations, but does claim that he has had the chickenpox. He has no known allergies, and the only medication that he's been taking is Tylenol, 500 milligrams, PO, 3 times a day for pain. George's family history: both parents are alive and well, and he is an only child. George does not use tobacco, uses alcohol 2 to 3 times a week, 2 to 3 drinks a week, denies recreational drug use, and exercises 3 to 5 days a week. He denies recent fever, chills, nausea, vomiting, or weight changes, does report recent headache, denies dizziness, changes in vision or hearing, no chest pain or palpitations, denies cough, shortness of breath, painful urination, frequency or urgency. On examination, George looked well but presented with an area of erythema on right side with tiny blisters that did not cross the midline of the body. The area was tender to the touch, and there was no other rash on the rest of his body. Shingles diagnosis is based primarily on history and physical findings. It presents with flu-like illness followed by dermatomal pain with no rash for 48 to 72 hours. The hive-like rash, increasing pain, is confined to affected sensory nerve distribution and does not cross midline. And eventually, blisters do evolve. In most cases, confirming diagnosis by lab testing has no utility. When treating shingles, we want to keep in mind the goals. And the goals are to shorten the clinical course, provide analgesia to the patient, prevent any complications, and decrease the incidence of post-herpetic neuralgia. There are lots of different therapies available and different medications. Medication choices are corticosteroids, which are usually used for complicated shingles. Agents for pain control can include narcotic and non-narcotic analgesics, neuroactive agents like TCAs, and anticonvulsive agents like gabapentin, which is usually used for post-herpetic neuralgia, and then antiviral agents, which we'll talk about. So the treatment plan for George. We definitely want to give him an antiviral because it's been within 72 hours of the onset of the rash. And antivirals can speed healing, reduce duration of symptoms, and reduce the risk of complications. Oral antivirals are indicated for patients 50 years or older, patients with moderate or severe rash or pain, shingles that involves the face or the eye, acute complications of infection, and individuals that are immunocompromised. For antivirals, we chose valcyclovir, 1,000 milligrams, PO, 3 times a day, times 7 days. Now, valcyclovir is the prodrug of alcyclovir. And for pain, he is in moderate to severe pain right now, so I'm prescribing some oxycodone at 5 to 15 milligrams PO every 4 to 6 hours as needed. There are also some home remedies that he can do to help with his rash and some pain, and this can include calamine lotion or compresses, and he can also take over-the-counter Tylenol or Advil if that helps him. It's also suggested to get plenty of rest and sleep. Some information about valcyclovir, otherwise known as Valtrex. So valcyclovir, the antiviral, what it does is it slows the growth and spread of the herpes virus to help the body fight the infection. This antiviral will not cure herpes zoster. What it does is it lessens the symptoms of the infection. The mechanism of action of valcyclovir is that it competes with the deoxyguanosine triphosphate for viral DNA polymerase to inhibit the DNA synthesis and viral replication. And as I mentioned, this is the prodrug form of acyclovir. Some kinetics about valcyclovir. It's rapidly absorbed, bioavailability about 55%. It's metabolized by the liver, and as I said, It's a prodrug, so it's converted to acyclovir, and it's done rapidly and nearly completely. It's widely distributed throughout the body, and only 13.5 to about 18% are protein bound. It's eliminated in the urine mainly, and minimally in feces. The half-life of valcyclovir is less than 30 minutes, and for acyclovir, it's 2.5 to 3.3 hours. And it's suggested to monitor baseline creatinine. Valcyclovir has both some serious adverse reactions and some common reactions. Serious reactions include acute renal failure and TTP, which is thrombotic thrombocytopenic purpura. Common reactions are headache, nausea, vomiting, and diarrhea. They also have some interactions contraindicated for the medication cidofovir, which is another antiviral for CMV. It is also suggested to either avoid the use or use an alternative for bacitracin, which is an antibiotic, and for talimogene laherpivir, which is a drug to treat melanoma lesions. And it's suggested to monitor interactions with cimetidine, which goes by Tagamet, which is an H2 receptor antagonist that's used to treat heartburn and peptic ulcer, and then bupropion, which is otherwise known as Wellbutrin, and then the diuretic chlorothiazide. Some additional information for George before he leaves the clinic. I want George to be informed about the natural progression of herpes zoster and its potential complications. I want him to know that during the acute phase, patients are infective and contagious to others and should avoid contact with elderly people, people who are immunocompromised, and pregnant women, and people with no history of chickenpox, especially infants or babies. I want him to know that prevention of shingles include the vaccine, which he should get, which I'll talk about on the next slide, and avoidance of contact with infected persons. I also want him to be aware that if he cannot control the pain or the itching, he should contact his provider or come back to the clinic. And then some additional information about valcyclovir, that it can be taken with or without food, and to drink plenty of fluids, and when to seek medical attention. The zoster vaccine is indicated for prevention of shingles in adults 50 years or older. There are currently 2 vaccines licensed and recommended to prevent shingles in the U.S. There is the Zoster vaccine live, which is Zostavax, which has been in use since 2006. And then there is the recombinant zoster vaccine, Shingrix, which has been in use since 2017 and is the one recommended by the ACIP as the preferred shingles vaccine. Shingrix is a 2-dose vaccination and is more than 90% effective at preventing shingles and postherpetic neuralgia. And its protection stays above 85% for at least the first 4 years after you get vaccinated. Zostavax is still available to prevent shingles in certain cases for adults 60 years and older. So I'm definitely recommending to George to get the zoster vaccination once his shingles clears up.